What would make a 14-year-old boy who's been 24/7 bed dependent seem to have a weaker voice now, even 6 months ago? Who wants to start?
What's his subtype?
Nemelin. Does that make a difference?
Certainly could.
Okay.
So first of all, I'm Oren Kupfer. I'm a pediatric pulmonologist in Children's Hospital Colorado in Denver. It's a pleasure to be here. I also want to thank the organizers for inviting all of us and for leading the most important topic to the exact middle of the conference, to be kind of a climactic event. So just know that that's what's happening right now, is the climax of the conference. So there are, I promise not to attempt any more humor. There are a number of reasons that voice can become weaker in neuromuscular disease. And so I think it's worth being systematic about it. I'm doing this off the top of my head, so please others jump in. But I would think from essentially top to bottom. So is there an upper airway obstruction? Is there vocal cord disease? Has the upper airway become more hypotonic or collapsible, such that air coming from the lungs cannot as easily as before pass through the vocal cords? Is there an issue with the tracheostomy stoma, such that there's more leak coming out of the stoma itself, and therefore less air going up and through the vocal cords? Does the ventilator need to be adjusted because the chest wall is less compliant and therefore can't accept as much air with the same amount of pressure? And is there an intercurrent illness or mucus obstruction that could be causing the voice to be weaker? So that's kind of the way I would think about it.
Yeah, so I'm Amy Boo. I'm a pediatric pulmonologist from Stanford University. I direct the pulmonary portion of the neuromuscular clinic, but I'm also an air digestive specialist. So voice and swallow is one of my specialties. So Oren got it correctly right, which is that the voice comes from something called your voice box, which is in the between your lungs and your throat. And so you need airflow through this passageway to create your voice. And so I actually missed in the question if the patient is treated with a tracheostomy or non-invasive, but you need enough lung volume to create your voice. And then you also need to coordinate the way you speak and breathe. So naturally, we're supposed to talk during exhalation, but sometimes if you're breathing fast or breathing insufficiently, that can get discoordinated. So sometimes you have to relearn how to speak actually. And so partnering with your speech therapist or your occupational therapist can actually help with your speech quality in a person who's getting progressively weak over time.
Dr. Kravitz, do you have anything to add?
I think everyone's hit all the topics very well. I would be worried that if someone's getting weaker in the voice, that they may be starting to have swallowing dysfunction, and we want to reassess their ability to swallow and make sure that's not a confounding feature.
Excellent. All right. I'm going to give this to Dr. Foley. How important is regular cough assist use? There are many things we need to do every day, and we often skip this.
So disclaimer, I'm not a pediatric pulmonologist. I'm Reghan Foley. I'm a pediatric neuromuscular specialist, but Rachel knows I spend 95% of my time talking about pulmonary and with the support of my colleagues. So I think we like to say the cough assist is the miracle worker, not to be forgotten, to be used daily as a form of exercise. We keep it often for the patient's tolerance and the inspiratory mode, kind of a maneuver. You can use it multiple times a day, in the morning, in the evening, but then during times of illness, of course, in the inspiratory and expiratory mode for expectorating or bringing up phlegm and coughing. So the question was,
do I have to do it every day? We have a lot of stuff going on.
Yeah, I would say, like a couple of our colleagues said in the college in 6 sessions, like brushing your teeth. So yes, like brushing your teeth. Yes, it should be every day.
Yep.
Yeah.
Skip something else.
So I'm John Pascoe. I'm a pediatric pulmonologist with a sleep background too at Cincinnati Children's. And I was in college in 6. And so with cough assist, it's sort of one more thing. It takes time to do, definitely. But, after sleeping overnight and secretions can maybe not be as mobile and hanging out down in the lungs. First thing in the morning when you wake up, clearing out the lungs is a great thing to do, definitely. And the other thing to think about with cough assist is it's also like a physical therapy maneuver. And so we've talked a lot about contractures, right? And so thinking about the rib and the spine as a joint is something that can also develop contracture and become less mobile over time. And so using the cough assist, which is a sort of proprietary term, so insufflation, exsufflation, that insufflation portion of it, you take a big breath and you hold it. It can really help to stretch the chest wall too. So it's serving multiple purposes by doing it.
Dr. Kravitz?
Well, I mean, I agree. I like the analogy about brushing your teeth, but I think in some ways it's more like flossing, and we only do the flossing right before we go to the dentist. I think in the ideal world, we would be doing it once or twice a day, both in insufflation and exsufflation mode. In insufflation mode for chest wall stretching, ligature stretching and the like, and for part of physical therapy. So in an ideal world, that would be, I would agree with that. But we live in the real world, and you're right, there are lots of different therapies. So sometimes we have to skip something here and then. The thing I would say about the cough assist is it should be used on a regular basis, but if you have to miss a treatment once in a while, it's okay, but it's ideal not to get into the habit of missing it 5, 7, 10 days out of a couple of weeks. Then you're going to get out, plus you're going to get out of practice. And when you need to use it for an acute process, we always want to make sure that the families and the patient are comfortable, so it's not sudden surprise. So I agree with my colleagues, it should be ideally used on a daily basis, but we all understand that there are a lot of things going on, and the question is, how do we balance all these things? And I think each family and each patient is going to decide what is in their best interest on any given day.
Great. Thank you. Okay, next question. So we know in the congenital neuromuscular conditions, small mouth, jaw contractures is a real problem, right? So then when you're trying to do a PFT and you can't get your mouth around the blow device, what's the alternative? Is there an alternative?
Yeah, I think that is challenging. So what the question's asking about is usually for spirometry, we use a mouthpiece that's round and big. So it's challenging for children who are small and challenging for children who have limited mouth opening. So what is in development is to use full face interfaces to measure that covers the nose and the mouth. Unfortunately, that seems to be only available at research centers who are doing other maneuvers that require full face coverage. And so at my institution, we do that. I am a proponent of advocating for our patients that we need smaller mouthpieces to fit our children, especially when standards of care state that we should be checking lung function down to 5 years of age, and these mouthpieces do not fit into our patients. So I empathize that is an issue, and that as a field, we do need to improve that. And measuring lung function in our younger patients, our patients who may not be able to follow instructions easily or don't want to follow instructions that day. And I think that is a gap in our field and that we do need to improve it. In the meantime, though, I do think that lung function measures do help answer that question of what do I need to prioritize today, or what do I need to prioritize in the next 6 months when other things are coming up in my life, as that last question alluded to, of doing the cough assist every day.
And in my muscle clinic, we routinely use full face mask for spirometry, recognizing either bulbar weakness with a wide open mouth that has a difficulty closing and creating a seal around the pneumotac tubing, or limited mouth opening that doesn't allow the tube to get in the first place. So we do full face mask testing routinely.
Okay. We're going to go back to cough assist for a minute. How many breaths should we be doing cough assist?
Richard, you want to take this one first? We'll give you first shot.
Okay. It can really vary, and a lot depends if it's for basic airway clearance or you have increased mucus that particular day. I usually use 5 coughs and 5 cycles per session, but it can be anywhere from 3 to 5 done 3 to 5 times per session. It really depends on what's going on at that moment. And also, are you adding in vibratory mode or not? So it's variable. It's also what you're comfortable with. So as long as you're getting enough effectiveness, that's the key thing. And, but going too little with too low pressures is not going to be useful. So you want to make sure you're going to get maximal bang for your buck when you do it.
So a couple of studies out of actually John's group in Cincinnati and out of Philadelphia suggested that for chest stretch, you really don't need that much pressure, probably 15 to 20 centimeters of water pressure, where our cough assists are usually set at more than that, 25 to 40 usually. So to get chest stretch, you may need actually less pressure. So if you're using it for that PT kind of mode, less pressure may be helpful. And then I will say in terms of coughing, none of us cough on an every 4-hour basis exactly 5 times. So if you're using it during illness, you should use it as much as you cough, which can be an unscheduled event, right?
You can't overdose on it, right? So whatever it takes. That said, if you're increasing it, we usually say, like we've talked about, right? Daily to twice a day when well, ideally if you can. And then when you're sick, probably at least 4 times a day. And you could do it every hour, but that's definitely something where you for sure want to let your team know, because then maybe that you need to be seen just to make sure everything's okay. But it's not something you can really overdose on. As far as the pressures go, the way that study determined the pressure was actually measured the lung volume that was generated by a given pressure, and then it kept on increasing incrementally until you saw that the change in volume did not increase by more than 10%, I think was our number. And so it really doesn't take much pressure to get that sort of maximal effect. And it's, I think, potentially a little more about the inhalation, like the time the breath is delivered, to really get open up the airways and stretch them out. So, yeah.
Okay. So I'm going to go suction in a minute. Speaking of breathing stuff, can we talk about managing daytime chronic hyperventilation? So tidal volume is already maxed out. Using daytime BiPAP settings. Does the tracheostomy the answer? I shouldn't leave during this part, I know. Can we resolve this with constant BiPAP? Discuss, and I'll be back.
And teals away. I think that it's a great question. Sort of there's different modalities that one can use to, and the question of when is it's the question of when to start that is also more just about sort of the symptoms that are there. It's not necessarily what number are you blowing in clinic, right? So while it definitely helps to see that perhaps the carbon dioxide level is a little bit higher, like more than 45, for sure that sort of sends some flags up for us. But I feel often before that happens, you're hearing patients say that I'm starting to fatigue later in the day, and I've actually just put myself on BiPAP, or non-invasive ventilation, I think is the way to really think about this, and feel better with it. And so as you're sort of alluding to, there's that nasal mask interface that could be used continuously potentially, but mouthpiece ventilation can be a game changer, really. And I think it's something that more is before wasn't as well known, and I'm seeing more and more of it, thankfully. And I think we have a huge proponent here. I'm not sure that he's here right now, perhaps, but at any rate, it can be an alternative to tracheostomy. And I think one thing to consider is you have the mouthpiece that potentially one can either sort of hold and support, or there's some brackets that can have it sort of supported for you and have it right at your mouth. And when that's the case, it is within your line of vision potentially. And so that might become pretty annoying through the day. And so for some, they wouldn't want to hold the circuit, and they wouldn't want to be taking breaths from that right in front. And so then you talk about tracheostomy tube, and you can still talk with a trach potentially, right? And it's all sort of, I think, personal preference and sort of talking about the goals that one has too with it. Clearly to ventilate, right? But in terms of other daytime function aspects, taking that into consideration. There's no right or wrong, honestly. The right thing is doing what the patient, what makes the most sense from multiple standpoints.
Yeah, so from as John was mentioning, there are objective measures where we say daytime support may be helpful to you, usually around a vital capacity of 30% predicted, or if your daytime CO2 is rising. That's nice for me to know. I'm not sure that our patients care what the vital capacity is. Like that, I don't know anybody that walks around knowing what their personal data is and acting on it just because it's a number. And so I usually ask my patients, well, if you're in a restaurant pre-pandemic, if you're in a restaurant, can you be heard? Right? If you want to get that second beer for the adults, please. Or, you know, if you want to change your order or whatever, you want to talk to your family in a restaurant, can you be heard? If you can't be heard, your voice is pretty soft and maybe you could use some support to augment your voice in the form of non-invasive ventilation. And that can be either, again, nasal interface mouthpiece or invasive through a tracheostomy. The other place I see it is in swallowing assistance. So if someone is breathing very fast or very hard because they can't expand their chest easily, then taking several breath stacking can increase the lung volume, allow them to breathe slower and more deeply, and then swallow more comfortably. So I think there's also a feeding component that could be helped with non-invasive ventilation. And then a final plug, which I don't know if we'll get to later, so I'll just mention it now. Tracheostomy is not a bad thing, and it's not a medical failure. It's simply another tool. So if it accomplishes what you want to breathe without things on your face or near your face, then it's worth considering. There's nothing about it that means that anybody has failed.
And can be reversed as well.
Turn my mic back on. There we go. As you can tell, I can talk on a trach. So that's one of the misconceptions. Can we talk about pectus excavatum versus chest wall deformity, when it would be appropriate to consider surgery, when not?
This is a tough one. It's so typically with pectus excavatum where the chest wall is caving in, right? So typically we think about surgical intervention when it's impacting like cardiac function potentially, or respiratory function too. And it's true, like to some, it's more of considered to be more of a cosmetic surgery potentially. And so that's why it's you wait until you're having some potential cardiac compromise or some respiratory compromise. To me, I think in this population, the surgical management, I've had a couple of patients with quite severe pectus, and talking with surgical colleagues, they're, putting a NUS bar in, which is a nickel bar that supports the curvature of the chest wall, and it sort of sounds very barbaric, but they can slide it in, sort of flip it, and pushes the chest wall out. But that is something that you would need to adjust over time as the chest wall grows, right? And especially in younger kids. And then the goal is that it would also be removed potentially. And with our congenital muscular dystrophies, I think that there's concern that the implosion would recur. So I think it's really tough to manage. One thing, just to say, and this is me sort of talking off the top of my head too, is when you think about respiratory function, the diaphragm contracts and pushes down, right? And air comes in. And so if you have a bit of a weaker chest wall, you're creating this vacuum in your chest essentially. And so if you have a weaker chest wall, it wants to implode. And so one consideration is, and all of us, I think, probably have some different practice styles, is overtaking the respiratory drive. And so that way the patient isn't using their muscle to trigger the ventilator. So in other words, the diaphragm's not necessarily contracting and creating that initial negative pressure for the chest wall to implode on. So it's sort of relieving the stress. And so you're just letting the ventilator do the work and using the positive pressure. And if one can overtake that respiratory drive safely, we've seen, if you do it early enough, we've seen chest walls change by doing that. And so it's sort of knowing the respiratory mechanics and how it all works, and doing some very fine tuning on the ventilator and looking at downloads as well, because the downloads from the machines can tell you average respiratory rate and especially like the percent of breaths that the patient is asking for. So it's great to shoot for a low percentage of breaths. So for me, like shooting for 20% of breaths or less being triggered by the patient, but just letting the ventilator do its thing to really allow for rest. It's a tough question and a tough topic. Open to
I totally
hear other
agree.
opinions.
Tough question, tough topic. It's often part and parcel of a congenital muscle disease. It's a degree of epectus, and it can be more severe in some and less severe in others. I personally haven't seen any of our kids undergo correction of that. And there is that probably pliability or plasticity at a younger age. That's why we rely on your input to maximize and help.
Oh, sorry.
Is there a difference between those two things?
So the question was difference between pectus excavatum and chest wall deformity.
Sorry for that.
Yeah, I think it depends on what your providers think is the cause, right? So I do have some patients with neuromuscular disease who are weak and but they don't have respiratory insufficiency, right? So on sleep study, on lung function testing, on blood testing, it seems like their breathing is fine, oxygenation, CO2 blowing out. And so pectus excavatum actually can be hereditary. Like that's the way your body was made. And so then in that case, yes, you can consider surgical intervention if you weigh the risk of doing surgery in a patient that has muscle disease. And also what is the impact, either way, what's the impact of that chest shape on that person? And if it's causing such mental health distress, that potentially it is worth it to make that decision. But it is, I would say in the patients that I have intervened, it's a long conversation over many months to make sure it was the right move to do for that person. But we want to really make sure that the breathing portion is well supported before we talk about the chest shape itself. But it is a complex discussion.
And I would challenge any physician to say that this is how you were born versus this is how you are because of your neuromuscular condition. I think that's impossible to say. And I've had patients come to me with neuromuscular disease who have pectus excavatum, and they were previously told, well, that's fine. That's a normal thing that some kids have. And when I saw it, it was clear to me that this was because of respiratory muscle dysfunction that the child had a chest wall malformation. And so the assumption that, or the assertion that this is just a chest wall deformity versus an outcome of respiratory muscle dysfunction is challenging. So I would say any infant with known or suspected neuromuscular disease with a pectus excavatum needs to see a pulmonologist immediately.
Yeah. You know, I would put, if I may, I would put, just to have a chance to follow this over time, I would put in a plug for all of us pulmonologists that we'd like to be involved in the care of your children, of these patients, before they're symptomatic from a respiratory point of view. We'd like to meet them at the time of diagnosis. We might not need to see you very often early on, but by getting to know you when things are well, when things are not too severe, we can monitor you over time and then help address what Oren just stated. This is related to your chest wall musculature, or maybe not. So get your pulmonologist engaged as soon as possible.
Yep. Okay. Surgery under anesthetic while on BiPAP. Why or why not?
Is it safe to do anesthesia under non-invasive positive pressure?
Yep.
Yeah, I think it depends on the surgery. So there's lots of different reasons that a person needs to be put to sleep. So sometimes non-invasive positive pressure can be applied safely if it's a short procedure, if it's potentially, I don't know, a lumbar puncture for some other disorders, or some skin thing, but the reason to be intubated during anesthesia is if you need a secure airway. And that's all for the safety of the patient, right? Like if the respiratory drive is diminished or decreased and the anesthesiologist needs to control that person's breathing, the safest way is with a breathing tube. And it doesn't mean it's a failure, it's actually safe. And the biggest conversation is to say, okay, how are we gonna get this breathing tube out? What is that transition once the patient is awoken, has finished their procedure, and how do we transition them back to their non-invasive positive pressure so that way they can be safely extubated and return to their state prior to that procedure? I'm not sure if that was the question.
Yeah.
I think in addition to that, we have to recognize that when we are trying to deliver air to the lungs and remove air from the lungs, but we are faced with the upper airway, the nose, the pharynx, the throat, the upper trachea, such that when people are put under anesthesia, all of those areas become less tonic. They collapse. And so if you are already hypotonic from your neuromuscular disease, and then you receive an anesthesia that could collapse this upper airway, it could be actually impossible to overcome that resistance with just nasal or facial airway pressure. So it may be actually safer, again, to put the breathing tube in. So we're trying to accomplish the same thing, but through different interfaces. And there's a real benefit to bypassing the upper airway in certain situations.
Definitely. And I think if one of the conversations was try and bilevel PAP or non-invasive ventilation during anesthesia, if it's lighter anesthesia, shorter procedure, if some of the thought process was it's known that the patient would be a difficult intubation, then I would really question the use of non-invasive, because say something goes wrong and you have a difficult airway, what next, right? And so, and with difficult airways, we can intubate over their scope. It's honestly not too hard for us to do. And so it's pretty safe. And then extubation wise, whenever you intubate, what's the plan for extubation? Then when extubation comes, what's the plan for reintubation if you need to? So making sure it's super safe. Sometimes you can extubate over a scope as well if need be, but extubating to full support is paramount too. So.
Yeah, and to add, I think John's point is outstanding. I mean, one of the concerns we have about intubation is, will I be able to be extubated, or am I going to need to go to a tracheostomy? And that's why I think it's really important that the whole strategy before, during, and after the surgery is discussed between anesthesia, pulmonary, and critical care to optimize the post-extubation period so that we have a successful extubation.
In my more advanced patients, I think we all have very frank conversations. And for one young man who's having surgery, I believe, or had surgery, I believe yesterday, the discussion was, I don't think you should have surgery unless you accept that it may result in the failure to get the tube out and needing a tracheostomy to continue living. That's the conversation we have. So if someone is shying away from that conversation, I think you guys as the advocates for your children or for yourselves should ask those questions. Not addressing the elephant in the room is a big problem.
Okay, thank you. Can non-invasive ventilation cause aspiration and scarring in the lungs?
Rich, do you want to cover?
I mean, it is possible. I mean, that's why you have to make sure that when you're doing non-invasive ventilation, that it's done in a safe and effective way. If a patient has good bulbar function, good control of airway and airway secretions, the risk that non-invasive ventilation will lead to aspiration is not zero, but it can be pretty small. On the other hand, if there's a lot of bulbar dysfunction, a lot of oral secretions, choking on saliva, things like that, then the risk of an aspiration event does go up, and that the approach has to be multi-systemic, multifocal. Can you dry the secretions out without over drying the airway secretions? Do you maybe avoid using positive airway pressure around the time of a meal or during the meal, or there are more effective ways. If someone needs non-invasive ventilation 24/7, can you switch to maybe a sip and puff ventilator during meals to decrease the risk of aspiration then? I think it's a multifocal approach to provide for optimal safety. But it can be it could be potentially a challenge.
I don't want to scare people away from non-invasive ventilation because we're aspirating saliva all the time. And so the connection of aspiration to scar, it needs inflammation. So it depends on the person and what you're actually aspirating. So all of us aspirate our saliva. We have an immune system in our lungs. There's a reason why we had recommended the cough assist, because we have our normal chest motion to clear that mucus from our lungs. And so I think that for this individual that's asking the question, that's why continuity of care is so important, to have you initiate the positive pressure, you see how it's gone. Is there any complications from it? Is a person getting aerophagia, which is swallowing air? Are they throwing up in the middle of the night because they're swallowing so much air? There was a conversation in the last session about air in the stomach and using other tools to help reduce that with abdominal binders, which I had not thought of, which is great to be in this meeting to think about, of how to prevent a person from swallowing so much air so that way they don't throw up. And then you have a fear of aspiration causing pneumonia, which then causes scar, right? So I think that follow up with your pulmonologist, expressing these concerns, being frank with the symptoms that you're experiencing at night will help address these. And there's interventions that can be made if that's what's going on.
Some patients really cannot tolerate non-invasive ventilation because of the aerophagia or swallowing air. And that becomes a very challenging situation where really we have to either manipulate the respiratory device, the ventilator, to try to limit that while still maintaining good breathing, or we have to consider other options. And those could be tracheostomy or negative pressure ventilation.
And in regards to the aerophagia too, the abdominal binder is a great idea. The one thing would be make sure that, so as you're laying flat, if you have a weaker diaphragm or even without, gravity is not your friend anymore, and your abdominal contents get pushed up against your diaphragm. And so if you already, and especially if you have a weaker diaphragm, and so if you end up that, you have the binder on, but you don't have your mask on yet, you may become really symptomatic and not feel great. And so I think having the binder on while sleeping, you propped up or lying flat otherwise, just make sure the support is on. And the one thing too, sort of a plug for sleep studies and titrations, is during a sleep study and testing different pressures, you can see that there's probably going to be an ideal pressure that's identified. It could be a higher pressure, and that's what generates some aerophagia. And so you may have tested some lower pressures that might not be perfect, but can still get the job done. And sort of like Oren is alluding to, adjusting the pressures. The sleep study data can sort of help guide you to like a little lower pressure. The CO2 is still okay. The respiratory rate might not be ideal, but that's okay. Or the CO2 might be not quite at goal, but it's much better than what it was. Sure, we can try this pressure and go from there. I've taken that approach for some patients, and it's actually worked pretty well too. So.
Okay, so we have a couple of questions about pneumothorax and a new vocabulary word for me, catamenial pneumothorax. We have someone who has had many lung collapses, always just before or during her period. And then another question about, does BiPAP cause pneumothorax? So I can just talk about pneumothoraces for a little bit.
I can start in one element of this, which is in certain subtypes of muscular dystrophy, in particular the collagen 6-way dystrophies, there is a proclivity or a tendency towards pneumothorax. Some children are actually born with a pneumothorax, not just unilaterally, but bilaterally, and then need really significant effort initially in the first few weeks of life to help keep both lungs inflated. And throughout the life of an individual with collagen 6-way dystrophy, there can be a recurrence of a pneumothorax. So it should always be on your mind that if you're having respiratory distress, to make sure that you're evaluated for a pneumothorax and treated if it is found. So that's my one comment there.
I am not familiar with catamenial or period-associated pneumothorax. I've seen catamenial hemoptysis or airway bleeding from endometrial tissue in the lungs, so pulmonary endometriosis. which is exceedingly rare, but we've seen it. Can BiPAP cause pneumothorax? I suppose theoretically, yes. The pressures we tend to use with BiPAP are not so high that I would expect the lung tissue to be able to rupture under those pressures. Usually, so when a person with normal respiratory muscle strength takes a deep breath and coughs, they can generate 100 or more centimeters of water pressure in the chest. What we use with BiPAP is usually, up to about 25 or 30 centimeters of water pressure. So I can't imagine it could cause a pneumothorax. Same, and then the same would apply to cough assist, frankly. Now, I have seen some patients with neuromuscular disease with pneumothorax, and I can't tell you that their BiPAP did not cause it, but there are other reasons that they could have a pneumothorax as well. So how's that for hedging?
Dr. Kravitz?
I agree with Oren. The risk, there's always the theoretical risk for any type of positive pressure ventilation leading to a pneumothorax, but on the standard pressures that we use, both for BiPAP non-invasive, even for tracheostomy and invasive ventilation and cough assist, the probabilities of causing pneumothorax just by that alone is pretty low. Usually it's going to have other multifactorial issues occurring that could be potentially leading to that. And as for period-related pneumothoraces, we always read about that. In pediatrics, I have to say I have no experience with that. I'd have to reach out to my adult colleagues to get their insight and guidance.
I want to put a little twist on the question, which is to ask another one: can BiPAP or cough assist perpetuate a pneumothorax? So let's say you've suffered the pneumothorax for whatever reason. Can positive pressure contribute? And the answer is yes, because what we want is for the lung tissue that's ruptured to heal, and under positive pressure, it may be forced apart and not able to heal. So we have to be very careful in patients with pneumothorax about what kind of pressures we're using. If they need respiratory support to breathe, then that's what we have to do. But we have to be thoughtful about how to manage it, either with a chest tube draining the pneumothorax so that the lung can re-expand and heal that way, or other methods.
Yeah.
Okay. All right, this is going to be a fight between our sleep specialists and our non-sleep specialists. Who should manage nighttime non-invasive ventilation? Your local pulmonologist or your sleep study specialist?
Why
can't they be the same person?
Yeah.
Often they are not.
Ideally, that is
which
so
is
true, though.
weird to me.
Yeah, that is true. I think so. It's helpful to, so for one, I guess just to mention the path to getting to sleep medicine. So one can become a sleep physician from pulmonary, neurology, ENT, psychiatry, internal medicine, pediatrics, family medicine too. Yeah, not anesthesia.
Psychiatry.
Psychiatry, yes, thank you, which they are so helpful. But so in other words, you may be having a sleep physician who doesn't have the respiratory physiology per se in their, as familiar with it, we should say, in their repertoire. And so I think it's really helpful having a pulmonary trained sleep physician. That being said, there's still some nuances to reading a sleep study that doesn't get calculated when you sort of push the button to make the report. You don't necessarily see the average respiratory rate that's split between dream sleep and non-dream sleep. Just to mention, in dream sleep, we lose muscle tone, and so we're largely dependent on diaphragm function. And so for one who's going to have weaker diaphragms, then you can imagine dream sleep becomes a big issue. And that's where often sleep disorder breathing first shows, and then will spread to the non-dream, like the full night, and then go on to the daytime from there. But I think that having a pulmonary background with a sleep specialist is helpful. And even so, then we end up doing, I think Rich, you probably would agree, we end up doing some educating there too, just because you don't necessarily always look for the respiratory rate of the individual. Hopefully we do. But because what we can see is that the CO2 monitoring, the number may be sort of high normal or mildly abnormal, but the respiratory rate's really high. And so the patient's compensating, trying to keep up. And so by our criteria from the sleep standpoint, they may not fully qualify for hypoventilation, if you will, but they're compensating for it. And so to me, it's the standard criteria for hypoventilation doesn't really apply to the neuromuscular community. So that's where having even sort of the neuromuscular background is helpful. It's tough. But.
Yeah, I have to agree with what John was saying. I've gotten into many arguments with my neurology colleagues who are also fine sleep physicians, and the CO2s are clearly elevated by pulmonologist standard, but they don't meet the American Academy of Sleep Medicine criteria for hypoventilation, so they read them as normal ventilation, and I have to go back in and put qualifiers on it. What I would emphasize is a lot of families will ask us, well, can I get a sleep study done in my community rather than having to come to the academic center? And in general, my request is no, unless they have expertise and experience in neuromuscular. And the one absolutely no-go is we do not do home sleep studies on our neuromuscular patients. They are great for standard obstructive sleep apnea and otherwise medically simple patient. Neuromuscular patients should not be getting home sleep studies.
So I'll put in the plug for the patient and family being the one in charge of their ventilation. We are here at your service. And if there's a disagreement between your pulmonologist and your sleep doctor, even if they're the same person, then it's really up to the clinical scenario and the person who knows the patient best, which is the family. And then if you have to defer to a medical specialist, then I would say that the person who knows neuromuscular disease, regardless of their training, is the person who should be helping make those decisions. So I often read between the lines in a sleep study, and I've not had much in the way of difficulty from insurance providers in getting what we need.
And I think our names are listed on Cure CMD too. So if there's ever any questions or concerns, you can please reach out. Actually, after Chicago, I think I had a couple reach out. And
I have a lot of questions I'm saving for later because we can't possibly, we'll be here till 10 o'clock tonight. You guys have amazing questions and I would love to answer all of it. I would like to plug KSSK CMD chats that all of these guys have been on to talk about pulmonary care from a very accessible space. So please watch that series. You can find it on our Cure CMD's website, and it's great for Nemlin and Titan too. It's not just CMD. All right, last question. Like I said, so many great questions. And you're not going to be able to answer this. It's the great part. Masks. I'm going to change the question a little bit. How do you pick a mask? How do you decide if it's working? Should you change it at some point? Like, we just talk about masks for a minute.
as in the interface for non-invasive ventilation?
Yes.
Okay, all right, just making sure.
Sorry.
Yeah. And this-
Not these.
I think so our preference is definitely nasal mask if you can, just because with if you're unable to remove the mask at night, say one gets aerophagia, feels sick and throws up. Then if you have a mask that's covering your nose and your mouth and you can't remove it, that could be bad and have a big aspiration event. And so we always try to do a nasal mask if we can. What type of mask, whatever works, as far as that goes. And so whatever's comfortable. There's some masks that are associated with maybe a little more leak than others, but honestly, a lot of my patients have the wisp, so something that goes around the nose. I think see a lot of head nods, right? For some, moving positions can generate leak as the trunk sort of pulls, and so there's other masks that just rest right under the nose but don't have prongs going in, and they connect on top. So one is called Dreamwear. And that I've had a lot of good luck with too. But in general, masks, whatever is most comfortable and is going to help help your kids to wear it all night, hopefully. And whatever, ideally sort of minimizing leak too if possible, but the nasal interface is the big thing.
What about open mouth sleepers?
Stuff.
Yeah, compensating for open mouth leak is difficult. Most of the ventilators actually can overcome a significant amount of leak, so it isn't often as big an issue as we think. We can certainly try to use chin straps to close the mouth a little bit. We don't need the mouth completely closed, so you don't have to like duct tape the face, but just keeping the mouth a little bit more closed to reduce the leak but not eliminate it can be helpful too. I still have safety concerns about that, but it can be done. And then in special circumstances, I'm willing to use a full or oral nasal face mask. So if someone has private duty nursing with someone awake and observing the child, then I'm more likely to be okay with it. So that's the technical aspect of a full face mask. The physiologic impact is actually that it's probably not as well tolerated anyway as just a nasal mask. From a physics and airflow standpoint, it's actually creating two different airflows, one through the nose and one through the mouth, with a palate in the middle that can vibrate and cause turbulent airflow, so that air delivery to the back of the throat and the lungs is actually more turbulent and not as efficient. So it's probably not as good anyway as an interface compared to a nasal mask. And then finally, many face masks will actually push the chin in and cause more upper airway obstruction. So it's another 2 or 3 reasons not to use a full face mask. And then the last thing maybe on this topic is that faces grow. And so refitting the mask is very important. So if you're seeing sleep quality change or nighttime awakenings or increased leak or desaturations, one of the possibilities for that, one of the causes of that could be that the mask is no longer fitting. And then because masks often sit in roughly the same place on the maxilla, they can actually cause facial deformities over time. So as bones are growing, especially in myopathic, weak muscled faces, the bone structure can actually be altered by non-invasive ventilation. So in an ideal world, each patient would have 2 masks with different pressure points on their face to mitigate those changes. I don't know very many patients who can tolerate and use 2 masks, much less 1.
And some who may be on it for longer than just overnight too, may alternate like nasal interfaces just to give some break for if there's any concern for skin breakdown and things like that, right? So off those pressure points.
Dr. Kravitz, any last
Yeah,
words on masks?
I agree with what Oren and John were just saying. If you have one mask that fits and is comfortable, you're in great shape. But getting a second or third is nice if you can rotate them to avoid pressure points. I was lucky; I had one young adult with Duchenne who had a mask for nighttime, a mask when he was sick, a mask when he was eating, and a mask when he was just out and about because he was on 24/7. He had a very helpful DME company that really worked with him. That he's the exception to the rule, but if you can have a backup mask or 2, that's great. And I agree with Oren's concerns about full face masks. I've used them, but it has to be just the right patient in the right circumstance to maintain safety.